All right, welcome everyone to session 9 of the Long-Term Care Certification in Infection Prevention Prep Group, where we'll be covering our final topic today, employee and occupational health. I'm your presenter today, James Callahan. I'm a registered nurse with 7 years of bedside experience, and I have also been working in infection control since 2020. I have been certified in infection prevention since 2022. My current role is as the supervisor of the IPAC hub in Michael Garron Hospital, where we provide IPAC support to local long-term care homes. Employee and occupational health is an area of expertise required for IPs in long-term care. Having the knowledge, skills, and judgment to minimize the impact of staff spreading and or acquiring infectious diseases while in the long-term care home environment is crucial to everyone's health. And with that, let's proceed. All right, so here is the title page, and I'd like to welcome everyone to session 9 of the lecture series. And as has been the standard of all of our LTC CIP prep group sessions, our agenda today is as follows. We're going to start by following the LTC CIP content outline as it's laid out on the certification board website. We'll start by discussing occupational exposures to infectious disease and some of the requirements for compliance with regards to these exposures. We'll review fitness for duty and work restrictions as they relate to communicable diseases. And finally, we'll discuss recommendations for employee immunizations for staff and what that looks like. Our first topic of today's lecture is occupational exposure. Not every staff in long-term care carries the same risk of acquiring infection or even spreading infection to residents while on the job. A type of risk assessment includes a job description-based risk assessment where you consider the role and the associated risks. This is as simple as asking the following questions. What poses a greater risk for infection? A cook with gastroenteritis or a medical record staff with a runny nose? When it's posed as simply as this, the strategy seems fairly obvious. However, as an IP, when you have a staff member call in sick with specific symptoms, your intimate knowledge of the home and the roles within it positions IPs, yourself as the IP with a unique perspective to evaluate the risk. There are also some legislated requirements for facility risk assessments. For example, in a facility with chronic bloodborne pathogens such as HIV, a post-exposure plan must be in place. So arranging an agreement between the facility and the local hospital emergency room can help expedite post-exposure prophylaxis in a timely manner. Job description-based infection risk assessments are sorted into 3 distinct categories: high, medium, and low risk, and this is based on how frequently the staff come into contact with resident skin or resident bodily fluids. So high-risk individuals are staff who are in frequent contact with this. Medium risk individuals are those who are infrequently in contact, and low risk individuals are unlikely to have any contact with bodily fluids or skin at all. This framework helps IPs assess the risk posed to staff based on the jobs that they perform. There are certain topics that staff in LTC should receive occupational health and safety training on upon hire and annually thereafter. So these topics include hand hygiene, environmental hygiene, personal protective equipment, and standard and transmission-based precautions. As IPs responsible for this education, we should consider our audience, who are all adults, and the drivers behind their desire and their ability to learn. Primarily, hands-on activities are much more useful than lectures or videos, and return demonstrations, so practical approaches, help to solidify practice in this learner population. The Occupational Health and Safety Administration regulations are required for all healthcare settings that have greater than 6 employees. These requirements include offering hepatitis B vaccination to all at-risk employees, utilizing standard precautions, implementing measures outlined in the Needle Stick Safety and Prevention Act, following tuberculosis control guidelines, and outlining specific vaccination requirements for staff. Language matters, and there's a large difference between must and should, and As IPs in LTC, it's your job to know where to look for this guidance. Having your LTC CIP designation will help with following these recommendations. Healthcare workers should be screened for communicable diseases like tuberculosis prior to assuming their work assignments. Sick policies should be written in a way that encourage staff to self-monitor and self-report illnesses that represent communicable diseases and minimize the impact of presenteeism. Presenteeism is a problem in healthcare, defined as coming into work, also known as being present while you're still unwell. If staff aren't compensated while staying home and while they're under the weather and they opt to come into work while they're sick, this promotes presenteeism, which can lead to issues in infection prevention control in congregate living settings like long-term care. OSHA also has requirements for injury and illness prevention programs in long-term care that are mandated for the following risks, not all of which pertain to IPAC. But these include MSK disorders, bloodborne pathogens like HIV and hepatitis C, tuberculosis and other airborne diseases, workplace violence, slips, trips, and falls, MRSA, and chemical and hazardous drugs. And to facilitate contact tracing in the event of the required epidemiologic investigations, medical files for healthcare workers on staff must be retained for a duration of employment plus 30 years, unless that employment has been less than 1 year. Bloodborne pathogen OSHA guidelines are required in certain circumstances. So, for instance, if any sharps are being used in the long-term care, a sharps disposal is required at the point of use. Blood glucose monitors must use hospital-level disinfectant with a kill claim for HIV or hepatitis B, and the use of engineered sharp safety devices are required. As IPs, we want to facilitate safety for our staff and as a primary prevention measure. So during your next IPAC audit, consider, are your sharp containers easily accessible at the bedside where blood work and vaccines are being given or blood is being taken? And what are we using to clean these glucometers between diabetic patients during our morning rounds? Another type of risk assessment that needs to be performed is the Sharps Safety Risk Assessment. So this requires actually developing and implementing a prevention program. It only applies to LTC facility staff and does not apply to residents who perform unassisted blood glucose monitoring. And potential HIV exposures should be treated within 2 hours of an exposure incident as per the APIC text. So when you think about needle stick injuries, everybody jumps to a concern about HIV. The real risk to staff, which is arguably more prevalent and carries a greater risk of transmission after exposure, is hepatitis B. So to manage this risk, OSHA again requires that Hep B vaccines must be offered with education provided within 10 days of potential exposure incidents. IPs must have the knowledge regarding this domain. So the hepatitis B vaccine series for adults is a series of 3 intramuscular injections, and the intervals here are outlined below. Some concepts related to these bloodborne exposures are as follows. Employees at risk for injuries with sharps must be tested for antibodies to hepatitis B surface antigen, anti-HBs, 1 to 2 months after completion of the vaccination series. Employees who do develop antibodies will have lifelong immunity. Employees who do not respond to the primary vaccination series must be revaccinated with a second 3-dose vaccine series and retested. Non-responders, so these are people who have no detectable antibodies despite vaccination attempts, should be medically evaluated. So let's talk a little bit about hepatitis B immunity and what that looks like. As IPs, you won't be responsible for the medical or prescribing aspect of treatment, but there is an expectation of understanding of the elements of hepatitis immunity. Hepatitis is a double-stranded DNA virus with multiple moving parts, and you'll want to know to be able to understand what represents immunity. You'll want to know the difference between the surface of the virus and the core of the virus, and the differences between antigens and antibodies. So the surface of the hepatitis virus is represented on the outside of the virus. These can be present as a result of infection or vaccination. The core of the hepatitis virus represents the inside of the virus, And this can only be present as a result of infection. So knowing this difference helps you, the IP, differentiate between these two variables. Antibodies, shortened to AB, represent evidence of an immune response, and antigen, shortened to AG, represents the presence of the virus. Simple, simple enough, right? So just like anything, interpreting hepatitis B immunity gets easier the more it's practiced. Two main antibodies to help differentiate between acute, an example, newly acquired infections, and chronic, which represents previous acquisition of the virus, are called immunoglobulins. Anti-hepatitis B core immunoglobulin M, IgM, is a marker of recent infection, and anti-hepatitis B core immunoglobulin G, IgG, is a marker of a chronic infection. And so there are many tricks to commit this to memory, and the one that I like to use is IgM, as I just met him, meaning it's new, versus IgG, which is I got him, which means it's old. And the final occupational exposure item we'll cover today is OSHA's TB exposure control plan. So knowing a little bit about tuberculosis itself and how it behaves, which is very slowly and sometimes very insidiously, can help understand why these recommendations are important. 1/3 of the entire population of the world is living with tuberculosis. Granted, the vast majority of that is latent TB. So let's use a little bit more regulatory language and discuss how long-term care homes must create a TB exposure control plan and review and update it annually. So the plan must have components that cover screening new hires and admissions, training and fit testing, training and education for employees on hiring and annually, fit testing employees for respirators, and if your long-term care home is accepting patients with suspect or confirmed infectious TB, your home must have appropriate environmental controls. If they're not accepting patients with active pulmonary tuberculosis, then you have to have a written policy for early identification and have a referral pathway cemented to an organization who can manage this patient population. So knowing about TB will also let you know that persons with active pulmonary tuberculosis can spread bacteria to others. So I want you to consider the chain of infection via airborne transmission. This means that staff with active pulmonary tuberculosis must not work in a congregate living setting with residents with active pulmonary tuberculosis must not reside in a home without adequate environmental controls. Namely, these environmental controls are AIIR rooms, which stands for Airborne Infection Isolation Rooms. All right, here is our first LTC CIP question of the lecture. So, a nurse sustains a needle stick injury from an HIV positive resident after drawing a blood glucose. Best practice recommends that they should receive post-exposure prophylaxis within A, 2 hours, B, 8 hours, C, 12 hours, and D, 24 hours. So I'll give you a minute to think about that. And then just think back to earlier in the lecture when we talked about facilitating a relationship with a community emergency department to facilitate quick treatment and quick prophylaxis administration. So the answer is 2 hours. All right, great. So the next topic for this lecture is called fitness for duty. So assessing for fitness to duty includes periodic health screenings to offer ways to check if healthcare providers have developed any potentially communicable diseases. Frequently screening healthcare workers for tuberculosis to ensure exposure or transmission has not occurred during employment or as a result of contacts with infected individuals in the community is something that's still recommended, although the guidelines are changing to recommend that TB screening should be performed on hire and upon initiation of employment and not annually. But for the exam, you'll want to say on employment and annually. And again, part of this fitness for duty is having a policy that supports staff to call in sick when they're unwell, and this prevents the occurrence of presenteeism. So what should IPs do when their staff report that they've been diagnosed with an infectious disease? What do we as how we as IPs share our knowledge and educate staff to safely return to work is part of infection prevention and control, all while protecting the vulnerable populations that we serve. So we don't get to make it up. The Healthcare Infection Control Practices Advisory Council, also known as HICPAC, have already made a series of recommendations for these. And as IPAC leads, you're not expected to know these by memory, but it is very helpful for the exam if you have a thorough understanding of them and you've been made aware that this resource is available. And these recommendations regarding restrictions for healthcare workers with specific diseases come categorized based on the strength of their recommendation. So I would recommend that as an IPAC lead preparing for the LTC CIP, you do commit these recommendations to memory. So let's walk through them. IA is a strong recommendation supported by high to moderate quality evidence. IB is a strong recommendation supported by low quality evidence. IC is a strong recommendation required by regulation, and II is a weak recommendation not supported by any quality evidence. And finally, sometimes in IPAC, we have no recommendations. So with that, let's jump into these HICPAC recommendations for work restrictions for healthcare personnel. So the next 4 slides summarize these recommendations in the tables and outline specific diseases and the problem, the work restrictions recommended by HICPAC, and the duration of the recommendation, followed by the strength of those recommendations. Again, you're not expected to have this memorized, but it is expected that you be able to interpret this table and understand the implications. And I will not be reading the tables verbatim to you right now, so feel free to pause the video or take time to read through the specifics. The first series of recommendations outlines hepatitis-specific recommendations. So when we think about hepatitis in LTC, hepatitis D is not pictured here. We consider hepatitis A, B, and C. So with Hep A, I want you to think about fecal oral transmission and consider restricting staff with acute hepatitis A infections from direct patient contact. This is due to the mode of transmission. With hepatitis B, consider the type of work this staff is going to be doing. Staff with Hep B who do not perform exposure-prone procedures, so we're thinking bloodborne transmission, have no work restrictions imposed on them. And if they do perform these procedures that would put them at risk for bloodborne transmission, consider having an expert panel. The recommendation is to consider having an expert panel review that takes into account specific details about the individual, about their competency, and about the procedures being performed. And there are no recommendations for hepatitis C. So by looking at this table, and just based on the word count alone, which of these 3 hepatitis viruses pictured do you think has the greatest capacity for transmission in a congregate living setting? So consider that when you're challenging the LTC CIP exam. And I'll just say it's probably the one with the most words. All right, here we have HIV. And so we're back again to the job description-based infection risk assessment. As IPAC leads, we know how HIV spreads. And any staff in LTC with HIV are safe to provide routine patient care as long as they are not performing these exposure-prone procedures. And I don't know many long-term care homes that are performing surgical interventions in-house. Measles comes with 2 sets of restrictions. So there's restrictions for those with active measles infection and restrictions for those who are susceptible and have been exposed to measles without proper protection. Excluding from duty is also known as furloughing, and staff who have active measles infection should be furloughed until 7 days after the classic measles rash has appeared. Post-exposure restrictions are interesting. So to account for the incubation time, workers exposed to measles should be furloughed from day 5 after the initial exposure to day 21 after the last exposure. And if an exposed staff member becomes an active case, you should follow that recommendation for active cases. So staff with crusted scabies should be restricted from patient contact until they're cleared by a medical professional. Staff with staph should be restricted during their acute infections and using routine precautions. So hand hygiene and using gloves when in contact with mucous membranes or bodily fluids should be sufficient source control for these Staphylococcus colonized staph. Tuberculosis recommendations, again, make sense when they're accompanied by a knowledge and understanding about how the disease behaves. So staph with active pulmonary tuberculosis should be excluded from duty until they're proven non-infectious, and staph who have latent TB or non-pulmonary TB should have no work restrictions or recommendations. And here's the final table. I know that these are tough to look at, and we're going to outline the varicella recommendations. So varicella is referring to what we know colloquially as chickenpox, differentiates between active and exposed staph. So basically, these staph should be furloughed until all their lesions are crusted and dried, and exposed. And for exposed staph, read the table to account for the incubation period. Interestingly, if immunoglobulins are administered, the staph is furloughed for longer. This is because the passive immunity granted through administration of IgGs or of immunoglobulins could potentially prolong the manifestation of the disease. And finally, zoster, also known as shingles, has 3 sets of recommendations. These are divided into localized in a healthy person, localized in immunosuppressed persons, and exposed staff members. All right, and here is the second LTC CIP question of the lecture. A new hire has a positive tuberculin skin test, TST, and has a chest x-ray that shows no pulmonary involvement. The staff is asymptomatic. Which resident population can they safely work with? So A, only tuberculosis recovered patients. B, any residents in long-term care. C, any with patients who have received the BCG vaccine. And D, exclude the staff from work until their TST is negative. So right off the bat, we know that the last one, D, that doesn't work. A isn't something I've really ever, it's not terminology we typically hear. And we know that that not all patients are going to receive a BCG vaccine. So the best answer is any resident in LTC. And if we understand the way tuberculosis works, this is the answer that makes the most sense. All right, and our final topic today of this lecture covers employee immunizations. So employee immunizations are something that IPs and LTC should perform as part of an annual assessment, as part of their occupational health program evaluation. And these recommendations and the knowledge that we have from vaccines-related science are constantly evolving. Now, there's a difference between having a record of immunization and a record of immunity, and we need to elucidate the difference. So not everybody vaccinated is going to be immune, and not everybody immune is going to have been vaccinated. This is because despite taking a vaccine, some individuals will fail to mount an immunological response, and these individuals are called non-responders. Employee immunization requirements can change from facility to facility. And while typically vaccines are not required, proof of immunity or at least knowledge of whether or not an individual is susceptible can be. For staff working with patients who need routine blood glucose monitoring, there should be a record of immunization or proof of immunity for diseases that could be transmitted via blood glucose monitoring, like hepatitis B. Varicella, measles, mumps, rubella, and seasonal influenza vaccines also could be outlined as part of a requirement for employment. So think of employee immunizations through the lens of protecting your staff so that they can maintain their health and they can continue working in providing the support that the residents in your LTC need. This also helps protect your workforce and the residents that are within it, because if all the staff are sick due to infectious disease, no one's there to help with the routine care. Here's a table outlining the recommended vaccines for long-term care healthcare workers. Notice that these include communicable diseases that are common in congregate living settings and pose a risk of morbidity and mortality to both your staff and your residents. Influenza vaccine is recommended during the respiratory season when we know that flu is circulating at higher levels. You could also say above the epidemic threshold. TD or Tdap vaccines are recommended for our residents in long-term care. This is consider that tetanus can survive in the environment and that the barrier protection for this population, an example, the skin, is prone to breaking and leaving a portal of entry for tetanus virus to get in. Shingles can be devastating for staff that are above the age of 50, and hepatitis B can have chronic consequences if transmitted by bloodborne pathogens. So for both hepatitis B, MMR, chickenpox, it's recommended to check the titers first to see if there's presence of immunity, i.e. antibodies are pre-existing. Vaccinations provided through long-term care homes to staff, members, and residents are required to be documented. This is the case this is required if in case there are vaccine adverse events, if there's contaminated lots of vaccines, and for evidence of immunization records. The details required are outlined on the slide being presented, which is, I'm sure we're all familiar with after a pandemic, which required multiple rounds of recommended immunizations. And here is our final LTC CIP question for this lecture. So susceptible healthcare personnel should be restricted from entering rooms of residents with which of the following infections and diseases? A, Mpox, B, hepatitis B virus, C, measles, or D, tuberculosis. And the answer is going to be measles. And we know that measles is quite contagious. And so that's something that's going to spread very easily. So that's where that recommendation is coming from. Great. And so here are the references. So all of this information was taken from the Infection Prevention Guide to Long-Term Care from the APIC text. And with that, we've concluded our lecture on employee and occupational health in preparation for the LTC CIP examination. So on behalf of the entire LTC CIP prep group, we'd like to express our gratitude for your time and attention, and we wish you the best of luck on challenging your examination. Thank you. All right.